Hello, my name is Dustin Anderson, and I'm here to talk about my comprehensive lower extremity evaluation for ATTR 810 Evidence-Based Holistic Healthcare 2. I'm currently a doctorate in athletic training student at Indiana State University. I work at Fort Sill, Oklahoma with the 179th Basic Training Battalion. The first thing that I found when I was looking at my comprehensive lower extremity evaluation was I never really looked at historical data or epidemiology of my population in depth. I think this is a vital tool in knowing what are the common injuries, where do they occur, what are some good preventative mitigative strategies for those injuries, and some of the best practices for treatment and rehabilitation of those injuries. So when I started looking for articles, I just asked myself some questions like, where do the injuries occur? When do injuries occur? Why do the injuries occur? And what can I do to, again, prevent, mitigate, diagnose, and rehabilitate those injuries? And I think this is the first step in a comprehensive approach to any type of injury question, is knowing what your population is susceptible to. One of the articles that I found that was really great was Musculoskeletal Injuries, Descriptions of a Unrecognized Injury Problem Among Military Personnel. It was a retrospective look at musculoskeletal injuries from 2006. The researchers used ICD-9 CM codes to find diagnosed musculoskeletal injuries. They found that they were 743,547 injury-related musculoskeletal conditions in 2006. And from the charts that I found, I made a little specific to this assignment with lower extremities. You can sort of see that the knees and the lower legs took the biggest brunt of the injuries for 2006. And pelvis, hip, and thigh, they're the lowest out of the three, but they're probably the most severe places to have injuries for military personnel. I know since I've been in the military, I've seen quite a bit of femoral neck stress fractures, femoral shaft stress fractures, and never really seen them until I started working with the military. So that's definitely unique for my population. Now, you can take this same approach if you were working football, basketball, or say you were working professional sports, college sports, Division 1, 2, 3, or high school or middle school. It's a good idea before you start any type of comprehensive approach to injuries to understand what your patient population is susceptible to, and definitely find the literature out on it. Now, a lot of people may not think about mental and physical strength as a component to overall evaluation, treatment, and diagnosis, but I thought it was interesting that we don't use more of like mental imagery, positive thinking, positive language when we're working with people with rehabilitation. I've seen it work with myself and others, that your mind's your best weapon. So I wanted to look and see if I can find anything with tactical athletes and any type of mental training, and see if there's any type of reverberations into the physical training. And I found this in the TSAC report from the National Strength and Conditioning Association. It was integrating mental and physical strength and conditioning for the tactical athlete. What does the research say? They looked at 5 questions. What's the nature of a performance mindset, mental toughness, and psychological performance skills? Do psychological factors affect human physiological response? Do psychological factors affect tactical performance? Does training mindset or psychological skill affect physical and tactical performance? 5, can mental and physical conditioning be integrated with performance benefits? They weren't really able to come up with any definitive answers. They just, with each section, they just gave a brief little blurb, and it was mostly people's opinion on this one. So There wasn't any concrete data that says yes, it does work, yes, it doesn't work. But I think there's definitely areas in here for research to see if it can with a tactical athlete. And it may be that there's some out there and I just didn't find it. But for the purpose of the article that I looked at, there really wasn't anything that said yes, it does, no, it doesn't. It was more of the jury's still out. And I think this is important when we're working with people as the whole body approach. Like I said earlier, your mind can either help you or hurt you. And I think if we can integrate a little bit more of mental training into rehabilitation, we could possibly see greater outcomes. And the most effective way that I've seen this is with fear avoidance. When you can get someone to actually meditate or visually go through a practice, a game, after they say they tore their ACL, rolled their ankle. Again, I don't have concrete data on that one. I've just seen that it works pretty well with fear avoidance. A pretty good hot topic is patient-rated outcome measures. And I found there's quite a bit of research on there out there of what it is. Some of the ones that I found that I could possibly use is the SF36, SF12, FAOS, FADI, and the list could go on. The biggest limitation that I've seen when looking at these with the research is that there's really none that's driven for the military population. So I don't know if I could use one and they would be a ceiling per se with my population. It might be the fact that I just have to do one. I have to just put one in and eventually see how that outcome measure is lining up with treatment and what the patient's saying. I think there's definitely a place for these in my clinical practice. It's still that it's been hard for me to find one that may be relevant, and every injury is a little different, and I think this would add just a concrete way of getting the patient's opinion on what's going on. And again, having maybe 2 or 3 in my back pocket for lower extremities, maybe 1 or 2 for the ankle, 1 or 2 for the knee, and the foot, and maybe like a health quality of life a patient rated outcome measure would be well suited for a comprehensive and whole body approach for lower extremity evaluation. It's just that I've not found one that I think may be significant for the military. Or on the other hand, it just may be that I need to try a few and figure out which one's the best for everything. And I think this is one of the biggest gaps that I have in my comprehensive care of injuries. And when it comes to kinetic chain assessment, I've used the functional movement screen quite a bit, or at least components of it. There's a lot of research out there that says it's got good reliability, validity, intertester reliability, and I've seen it work well as far as giving you a numeric value for movement. But I've said it before in past assignments that I think it's just a good flatline assessment. But if you don't give good correctives, there's nothing's going to happen. And I also think you can get pretty much the same thing with a gait assessment and functional testing. And functional testing, I think, should be specific to the sports that you're playing or your patient population. With the military, I always like to do a Y squat, a push up, and a double leg hop, single leg hop. I also think adding like the STAR excursion balance test would be great from where I'm working. I haven't had the room to put it in before, but I have a bigger place now, so I think I'm going to definitely put in that test. But as far as the functional movement screen goes, as a kinetic chain assessment, you got to ask yourself, is it worth the money, and can you get the same thing done with a gait assessment and functional testing? I know I didn't really talk about the traditional things we would think about with a comprehensive lower body extremity evaluation, like history, our objective information and everything else. I think everybody has a good basis on that. So with this assignment, I really tried to look at some out-of-the-box things that I could add in to further my clinical skills and my evaluation of the patient. And I hope you've enjoyed, and thank you for your time.